All right, today we're headed straight into the ER. We're going to be talking about a really serious injury, one that happens way more often than you'd probably guess. We're talking about renal trauma, kidney damage.
Okay, so picture this. You're in the middle of a chaotic trauma bay. A patient just got wheeled in from a really bad accident. The whole team is moving like a blur. They're checking for all sorts of injuries, but there's one specific vital organ that gets hit a surprising amount of the time. What do you think it is?
Well, the answer is about 10% of the time. Think about that. 1 out of every 10 major trauma patients. That's a really significant number in the world of emergency medicine, and it tells us there's a part of our body that's, well, a lot more vulnerable than we might think.
And that vulnerable part of our anatomy? It's the kidney. I know, right? It's tucked way back there behind the ribs, deep inside your abdomen. You'd think it would be one of the safest organs in your body. But that's the paradox we're going to explore. It's hidden, but it's also incredibly vulnerable.
So how can an organ that's so protected get hurt so often? Let's break down the anatomy of how these injuries actually happen.
You know, the damage can be anything from a simple bruise, what doctors call a hematoma, all the way up to a kidney that's literally fractured. But here's a really interesting and kind of crucial detail for one specific group of people, those with transplant kidneys. See, those kidneys aren't placed deep inside. They're much more superficial. They don't have that natural armor of the rib cage, which means they're at a much higher risk for injury.
Okay, so the team suspects a kidney injury. What now? Well, this is where they basically turn into detectives. They're on the hunt for clues that are going to confirm there's damage and, just as importantly, tell them exactly how bad it is.
And these are the classic red flags they're looking for. If a doctor sees any of this stuff after a trauma, you can bet the alarm bells are ringing. Gross hematuria, that's just a fancy way of saying you can see blood in the urine. That's a huge one. And if you combine that with low blood pressure or obvious signs like broken lower ribs or some serious bruising on their side, yeah, they're definitely ordering a scan to see what's going on.
Which of course brings us to the CT scan. This is the absolute gold standard for diagnosing these injuries. And it's not just one quick scan. It's this really cool, carefully timed 3-part protocol. So first up is the arterial phase, which lights up all the main arteries. Then, about 70 seconds later, you get the portal venous phase, which gives a great picture of the organs. But for kidney trauma, the real magic happens in this third, delayed phase. They actually wait, sometimes up to 15 minutes, to see where the contrast eye ends up. It's specifically designed to catch those tricky slow bleeds or, and this is super important, any urine leaks.
And this is such a great illustration of what they're hunting for on that delayed scan. Let's say they see a little pool of contrast dye. If that pool gets brighter and denser over time, boom, that's active bleeding. But what if that same pool of contrast actually fades or washes out? Well, that points to something totally different, a pseudoaneurysm, which is this really dangerous ballooning of a blood vessel wall. See? 2 completely different, very serious problems, and they can tell them apart with the same exact test. It's pretty amazing.
All right, so the scans are done, the detective work has paid off. Now it's time to take all that information and put it together to give the injury an official grade.
And they don't just wing it. There's a standardized system that trauma surgeons all over the world use. It's called the AAST Renal Injury Scale. That's from the American Association for the Surgery of Trauma. It's a simple 5-point scale that basically gives everyone a common language so they're all on the same page about what they're dealing with.
So here's a quick look at the whole system at a glance. You can see how it builds logically, right? It starts with a simple bruise at grade 1 and goes all the way up to really severe stuff in grades 4 and 5, where the kidney's plumbing or its main blood supply is compromised. Let's walk through it grade by grade.
Okay, starting easy. Grade 1. This is the most minor injury you can have. It's what's called a subcapsular hematoma. Just think of it like a bruise that's stuck underneath that thin little skin that covers the kidney. The most important thing to remember here, no tear, no laceration, just a bruise. Now we step it up to a grade 2. This is where we see the first actual tear in the kidney itself. It's a pretty shallow one though, less than a centimeter deep. And any bleeding from it is still nicely contained right there around the kidney.
Grade 3, things get a little more serious. Now we're talking about a deeper tear, more than a centimeter. But, and this is the critical distinction for grade 3, the cut has not reached the internal plumbing. It hasn't gotten to the collecting system where all the urine is. And that means, most importantly, no urine is leaking out.
Okay, grade 4. This is a major jump in severity. That deep laceration we talked about. Now it has torn all the way into that collecting system. So you've got urine leaking out into the abdomen, which is a big problem. This grade also covers injuries to the main arteries or veins that feed the kidney.
And that brings us to grade 5. This is, well, it's the worst case scenario. We're talking about a completely shattered kidney, like broken into 3 or more pieces, or a devascularized kidney, which means the main artery has been totally ripped apart and the kidney has no blood supply at all. It's a catastrophic injury.
So, there you have it. The injury's graded. The team knows exactly what they're up against, and this knowledge brings them to a massive decision point, what I like to call the treatment crossroads.
And honestly, this right here is probably the most important takeaway of this whole explainer. This grading system isn't just some academic exercise. It directly tells the doctors what to do next. If you've got a grade 1, 2, or 3, you're usually looking at conservative management. That means bed rest, observation, just letting the body heal on its own. But the second you cross that line into a grade 4 or 5, with a urine leak or a major blood vessel injury, that patient is almost certainly heading to the operating room.
Because at the end of the day, it all boils down to one guiding principle. Save the kidney whenever you possibly can. And this super precise systematic grading scale, it's the roadmap. It's what gives the surgeons the confidence to make that huge life-altering call between let's wait and see and we have to go to the OR right now.
So that leaves us with one final thought to chew on. This system works incredibly well, right? But it's all based on the imaging technology we have today. So what happens as our diagnostic tools get even sharper, with better, faster imaging, or maybe even brand new biomarkers that can tell us more about the injury? How might that change this crossroads between observation and surgery? Is it possible that someday we could manage even some grade 4 injuries without ever picking up a scalpel? It's a really fascinating question for the future of trauma care.